I'm Dr. Larry Burchett, and welcome to your 5-minute weekly coronavirus update for August 21, 2020, powered by AverPoint.com. This week with Dr. Linda Sharp, MD, making her debut, and Shouvik Banerjee, the founder of AverPoint. Linda will talk about Latin American communities in the United States. I will explain to you the Ace2 receptor and why that matters for coronavirus. And Shouvik will kick it off, as always, with the numbers. Shouvik?
This was the third week in a row America saw over 1,000 deaths a day from coronavirus. 20 days in August, 20,000 deaths. But daily new cases fell 10% to 47,000. Hospitalizations fell 10% to 43,000. Now these are big numbers, but they're moving in the right direction, and we hope the death count comes down soon. Now, US testing has been erratic since the start of the pandemic, and this week was no different. Tests shot up, then tests went down, but there were 3 bits of important good news. The positivity rate in all regions has come down. This is good. This means local testing capacity can better get its arms around an outbreak when it occurs. Now, the big labs, LabCorp and Quest, announced their testing times have fallen from over a week to 1 to 2 days. People are getting their results when they're still contagious and can better stop spreading the infection. And third, more places are getting their hands around rapid antigen testing. These are less accurate tests, but they get results in 15 minutes to 3 hours, and they can be done anywhere. And these help places like campuses, workplaces, sports teams, and quickly identify who's infected and take action. Now, everyone's wondering about school reopenings. And remember, places around the world, countries around the world, have opened schools safely by taking safety measures like wearing masks, outdoor classes, staggered start times. In the US, many schools opened in the last 2 weeks, but they quickly had outbreaks. These are places where protective measures are not popular, and we saw outbreaks in Notre Dame, Texas Tech, UNC, Chapel Hill, K-12 schools in Florida, Georgia, Tennessee. And this is adding to the argument that it's hard to reopen schools safely in the US because our divided views on masks and social distancing. Now, the world continues to report over 1 million new cases every 4 days. This week, India made headlines, joining the US and Brazil with over 1,000 daily deaths. Now, they had implemented the world's largest lockdown early on, but as they reopened their economy, the numbers have slowly gone up, and this week they accelerated to 65,000 daily cases, eclipsing the US. Now, let's talk about South Korea, the poster child of pandemic management excellence. They contained the virus in March through rapid testing and saw barely any cases until August. When they had a small outbreak, they did testing, they quarantined, and they stopped it in its tracks. But for the past 7 days, they've had triple-digit cases every day. What happened? Well, they had an outbreak in a church led by a radical preacher who urged members not to do testing, not to socially distance, and not to follow protective measures. So South Korea is having a hard time containing this particular outbreak. So we'll keep an eye on this and all the numbers, but now we turn it over to Dr. Sharp.
As a follow-up to a previous episode, I will be discussing some of the reasons why COVID-19 rates are higher in the Latinx community. I'll also talk about what makes undocumented immigrants among the most vulnerable to COVID. The latest CDC report shows that Latinx communities are 2.8 times more likely to be infected than whites, 4.6 times more likely to be hospitalized, and with a slightly higher mortality rate compared with whites. As Dr. Jones previously shared, social factors contribute to the increased rates of COVID-19. Latinx workers make up a large proportion of essential workers and are less likely to work from home and thus more likely to get COVID-19 in the work environment. Latinx families are more likely to be living in multi-generational and sometimes crowded housing, which can also increase spread. Latinx communities also have the highest prevalence of diabetes in the United States, as well as high rates of obesity and hypertension, all risks for severe COVID-19. Finally, the undocumented communities in the United States are among the most vulnerable and have the most barriers to seeking both testing and care for COVID-19. These individuals are excluded from many public benefits, and most lack health insurance. Fear of deportation and family separation, and worry about community raids by Immigration and Customs Enforcement, aka ICE, keep people from seeking testing and treatment for COVID. making it more likely that undocumented persons can become sick and spread COVID among family members. During a global pandemic, fear of seeking healthcare can mean delaying getting tested for COVID, unrecognized cases, and missed opportunities for contact tracing and infection control, and is one contributor to the higher numbers seen in Latinx communities.
Have you heard about this Ace2 receptor? It's a protein on human cells that COVID needs to enter the cell. You could think of it as the lock that COVID only has one key for, or if COVID is a ship at sea, it needs this particular dock to land. How did scientists figure this out? In 2003 with SARS, also a coronavirus, this was discovered. Initial studies showed that cells that had more of this ACE2 protein were more readily infected by the virus, whereas those cells that didn't have as much of this protein were not as affected. Now, researchers at that time were also impressively able to demonstrate this down to the atomic level. Again, this ACE2 protein, the lock that COVID needs and has the key to enter, it's abundant on a certain type of lung cell in particular, called the type 2 pneumocyte. Pneumo just means air, cyte means cell. This lung cell is in a part of the lung called the alveoli where oxygen and carbon dioxide are exchanged. So this makes sense because coronavirus causes so much respiratory failure and low oxygen. You can see why this receptor in that key part can result in so much of this disease. Now, COVID unfortunately doesn't stop in the lungs. There are other organs and tissues in the human body that also have this ACE2 protein, such as the heart, kidneys, and intestines, to name a few. And COVID can damage those systems in the same way by entering the cell through this receptor. Well, what does ACE2 receptor do and what does it mean? Angiotensin converting enzyme. The angiotensin system raises your blood pressure when you're dehydrated or your blood pressure is low. So your blood pressure drops, the body releases these hormones and activates them, and your blood pressure goes up. Now, when things are back in balance, ACE2, our receptor, is involved in shutting this pathway down. So it helps keep things in balance. Now, not only does this system raise blood pressure, but it also increases inflammation and clotting. And it's thought that COVID, using this ACE2 receptor, means that that protein, which is normally able to help control blood pressure, inflammation, and clotting, is unavailable and not able to do this job. And so that, along with other mechanisms like cytokine storm that we've discussed, are some of the ways that COVID causes inflammatory damage, again, not only to the lungs, resulting in ARDS and pneumonia, but also resulting in clots to the brain like strokes, clots to the lung, PE. This ACE2 receptor is really crucial in the disease pathology. So if this is how it works, how can we use this knowledge to fight back and block this process? Some biotech companies are approaching this by flooding the system with more ACE2 proteins, so COVID binds to them instead of on our human cells and on our proteins on our human cells in the lungs. Another approach is to block this ACE2 receptor, preventing coronavirus from attaching to the protein in the first place. Kind of like putting a key in the lock before COVID does. Clinical trials, of course, are underway. These days, along with using this knowledge to find a vaccine, that's the billion-dollar question we're all hoping to discover sooner rather than later. For Dr. Linda Sharp and Shouvik Banerjee, I'm Dr. Larry Burchett. Thank you for joining us for your 5-minute coronavirus weekly update. We hope you found it useful. Please share this video. You can interact with the evidence yourself on AverPoint.com. As always, stay safe, do your part, and we'll see you next week.